you've stated clearly at the root of all of this is dysfunction with the mitochondria. And now I want to tie this into the diet piece from a prevention standpoint. So we'll talk about the ketogenic diet. How does that support the mitochondria in prevention? And then we'll get to treatment later.
Okay. It does it through a number of ways. And the optimal diet for cancer prevention may not be the ketogenic diet. For some people are, in particular, people who are obese, type 2 diabetic, overweight. It's a very effective way to get insulin under control. And when we suppress the hormone insulin, that activates metabolic machinery to increase our fat oxidation capacity and our ability to make ketones, and actually limits or marginalizes glucose as a fuel source. So it makes us more metabolically flexible. And the standard American diet, eating multiple, high carbohydrate meals throughout the day in and day out, largely suppress metabolic flexibility, where in the past, of course, we had limited food availability and we did not have access to the amount of carbohydrates we have now. So we were metabolically flexible in the past, and it's debatable, but maybe that's why we didn't have the high rates of cancer way back in the day. Or of course, we didn't have the diagnosis and imaging technology to diagnosis. So people just died for unknown reasons. But I think even epidemiologists agree that, cancer is a disease that is far more common today than it was in the past, right? So I think that's important to appreciate. A ketogenic diet kind of brings us back to our evolutionary past, in that by eating a ketogenic diet macronutrient ratio that's high in fat, sufficient and moderate in protein, not high in protein, and the carbohydrate source is largely fibrous carbs from vegetables. So you have fat, adequate protein, and fiber. And this diet suppresses the hormone insulin, which is a really important component in regard to cancer outcomes. And it also reduces blood glucose levels to some extent, not too much baseline glucose, but it does it reduces the glycemic variability. So, or spikes. And actually those spikes in glucose are triggers for other pathways, other growth factor pathways. Like when you could have a normal baseline glucose, but if you have a periodic spikes in glucose, it's releasing insulin, and that relative change in glucose then is the driver for releasing insulin, which can then augment and change IGF-1, mTOR, and other pathways associated with cancer growth. So a ketogenic diet really takes the foot off the gas pedal of cancer growth, if you have it, and it actually produces an environment that makes it less likely that cancer would grow or even initiate. That's what we believe, and I think if you go back to the calorie restriction studies, this was seen. And I think an important thing to acknowledge too, that if you have any diet and you reduce calories, or you do it intermittently, and you control insulin, you control glucose, and you keep insulin, or you keep inflammation low, those three things, I think it would be very similar to the cancer suppressive effect of a ketogenic diet. So you could do that with any diet. The advantage of a ketogenic diet is that it likely makes it easier to adhere to caloric restriction, which can be very helpful for many patients. Also limiting that glycemic variability, reducing insulin a little bit more, and then you have the production of ketones. So the liver produces ketones, but can't use ketones as an energy source, lacking succinyl-CoA transferase, unless you have like liver cancer. So the liver is almost like an endocrine organ that's releasing this, fuel that the body's using, this endogenous metabolite that is not only providing energy, but it has its own receptor, GPR109A receptor, as an example, and that can trigger a reduction in inflammation. It has epigenetic effects through histone deacetylase inhibitor enzymes. It directly interacts with the histone via beta hydroxybutyrylation, which is a whole pathway a graduate student of mine is studying right now. So not only is it an energetic fuel that can increase ATP production per unit of oxygen, perhaps even 20% higher ATP production. We know that's the case with the heart. No one has validated that in the brain or muscle, but cardiac muscle they have. So you have a fuel that is more bioenergetically favorable when it's metabolized. It produces less reactive oxygen species. And then it also functions in a way that can increase our antioxidant capacity. It has favorable epigenetic effects, and it changes various signaling pathways that would favor a suppression of cancer growth. So that's the advantage of the ketogenic diet. But, taking a big step back, if we just focus on our body composition, if we, keep a healthy weight, if we stay active, exercise, maintain strength and vitality with any diet, that's probably the most important thing. But the ketogenic diet is kind of like the icing on the cake. And when we talk about a ketogenic diet that puts your glucose ketone index within the range of like 1 to 3, then that is what I call a prescription ketogenic diet. There's like the internet ketogenic diet, right? And then there's the prescription strength ketogenic diet. And that's a highly calculated ketogenic diet that needs to be managed, that keeps your glucose ketone index, which is the ratio of your glucose over ketones in millimolar concentration, that ratio between 1 to 3. And that in and of itself has incredible anti-seizure neuroprotective effects, but will have tremendous tumor suppressive effects, and would further augment the therapeutic efficacy of standard of care therapies, including radiation, chemo, and immune-based therapies like checkpoint inhibitors, PD-1 inhibitors, for example, would be augmented by that metabolic state.
You quickly touched on the fact that this diet could help with seizures, and it gets me thinking about the fact that what we're talking about today, we're directing it at cancer, but this diet has so many benefits when it comes to you follow this down and it fixes the metabolic health, which is related to so many of the chronic health conditions. So again, we're
Yeah.
taking this lane of cancer, but it applies to so much more.
Yeah. So we call this it's multifaceted pleiotropic effects, right? So and that makes it very difficult to study too. A lot of people ask, well, what's the difference between a ketogenic diet and just giving like exogenous ketones, which is another topic. It's like a hack really to lower your glucose ketone index. And similar to giving a fuel like exogenous ketones, when you alter metabolism and shift the metabolic machinery and also the fuel that it's using, you are changing so many different downstream pathways, and it's hard to disentangle and identify specifically what is favorably changing, and that might be different depending upon the person. One person may have an insulin level of 20, right? And a ketogenic diet may bring it down to 5 or 6, and that's beneficial. Another cancer patient may have a normal insulin of 4 or 5, but they may be benefiting from, the higher ketone levels and maybe the anti-inflammatory state of that. So it's hitting many different. If we had a drug that did all these different things, and I mean, the closest thing that we have is maybe metformin, and there's some side effects to that, right? But if we had a drug that did this, it would be a blockbuster for sure. And I think that's important to acknowledge that from the context of people asking, well, where are the human, randomized clinical trials, which we do have for epilepsy, but where are the RCTs for cancer? We have quite a few pilot studies show it's feasible and that it's efficacious under some conditions. But they still, I mean, doing nutrition research is incredibly hard. I was talking with Dr. Jeff Volek yesterday, who's like a pioneer in this. Actually, he's doing quite a bit of cancer research. Um, so it's just hard to do this kind of research. And but if you go to clinicaltrials.gov, and people listening to this can just go to clinicaltrials.gov and type in ketogenic diet and cancer, and you'll find at least 3 to 4 dozen clinical trials for cancer. And 10 years ago, there may have been 2. So it's very reassuring that this has been put on the radar. There's even some federal funding supporting it, but it is not purely a non-toxic metabolic therapy. So what institutions are doing or pharmaceutical companies are doing are actually using the diet to further enhance and augment specific drug therapies. That could be the case for metabolic drugs too, like PI3 kinase inhibitors, for example. So I think Dr. Lou Cantley kind of spearheaded this class of drug, which on paper, I mean, these seem to be remarkably promising, the idea of a PI3 kinase inhibitor. But when you administer these drugs, there's a counter-regulatory effect that causes your insulin to surge. So the elevation of insulin associated with PI3 kinase inhibitor drugs then negates the effect of the drug by itself, because insulin can enhance cancer growth by increasing glycolysis and other growth factor pathways. But in the context of a ketogenic diet, a PI3 kinase inhibitor, then you sort of unleash the beneficial effects of a PI3 kinase inhibitor in the context of insulin suppression through a ketogenic diet. And a lot of high-level investigators that are publishing papers on ketogenic diets, and they don't even put it in the title. They'll say like insulin suppression therapy plus drug X, improves cancer outcomes. And you look at like, what's the insulin suppression therapy? And I'm not going to mention names here, but it could be, in one case metformin, but insulin suppression therapy is a ketogenic diet, but as cancer researchers, federally funded, there's a stigma to the diet. And that actually prevents a lot of people from talking about it, I think. And I've never been shy to talk about it, but I was a neuroscientist physiologist that kind of stepped into the world of cancer. So I viewed cancer as something that was very difficult to understand. I think it still is. But when you approach it from the context of like a physiologist and cell biologist, it started to make more sense from the perspective of a metabolic component. And there's a lot that I don't understand from a genetic and epigenetic standpoint. But what I do know is that there's a grossly underappreciated metabolic component of cancer that has been utilized by an FDG PET scan, but that metabolic component has not been leveraged, or targeting it has not been leveraged from a therapeutic standpoint. So that was the case in 2009 or 10 when I started studying it. It's still the case now, but it is actually ramping up to where now there's actually conferences on cancer metabolism focused on these pathways.
We've gone over quite a bit already and gotten into a lot of nuance, which is great. I just want to try and tie some of this together for people. We started off saying that the metabolic theory states that the origin of cancer is dysfunction with the mitochondria. And when we got into the ketogenic diet, we talked about how that helps with inflammation, helps regulate insulin and keep that down or keep that more balanced. How do those tie together? So when it comes to inflammation and insulin tying to the mitochondria, like we opened up, is there a connection there?
Yeah, well, if we look at epidemiological data, and that's not always the most reliable data, especially in nutrition. But if we look at epidemiological data, it's very clear that higher blood glucose or hyperglycemia and hyperinsulinemia is associated with much greater, sometimes 2 to 3 to 4-fold higher incidence of cancer, right? And the hyperglycemia and hyperinsulinemia is associated with an elevation of even systemic inflammation like CRP or high sensitivity CRP, C-reactive protein, or certain inflammatory cytokines. And that metabolic dysregulation creates fertile ground for a transformed cell from a healthy cell that has transformed into a precancerous cell to take root and then proliferate and grow. And then as that tumor grows, it becomes larger. And as a tumor grows, the core of the tumor, as a tumor grows, it outstrips its ability to supply blood and oxygen to it. So this is like the core of the tumor. And then the tumor, the mass of cells that then become a tumor becomes even more genetically dysregulated with more mutations occurring from the hypoxia at the core of the tumor. And the hypoxia further damages the cells of the tumor, and it becomes more aggressive, right? And then as it becomes more aggressive, then it starts meeting all the hallmarks of cancer, right? You have, insufficiency of, growth signals and immune evasion, and then most importantly, invasion and metastasis, where clumps of tumors can come off, they get in circulation, and then they seed, for example, in the liver and the kidneys and the lungs, and then they become metastatic. So most people don't die of a tumor per se, unless it's maybe a brain tumor, but people die of metastatic cancer. So actually the model that we used is an excellent model of cancer because it's a highly aggressive model of metastatic cancer. And this was developed by Thomas Seyfried. And it's a unique model, the BMM3 model, because the primary tumor was a brain tumor, glioblastoma, but we use an inbred strain of animals, the VMDK mouse. And when we take these cells out, dissociate them, plate them, grow them, and implant them into the flank, then you have very rapid systemic metastatic cancer, and becomes a very powerful model. And it also features cancer cachexia and muscle wasting, which is termed cancer cachexia. That's a unique feature of the model. And one of my PhD students studied that. So that's the features of cancer that could be targeted by a protracted ketogenic diet, not only a ketogenic diet, but a diet that's low in carbohydrates, a diet that moderates calories in a way that optimizes metabolic biomarkers and cardiometabolic biomarkers that produces a physiological state that would make it less likely for cancer to occur. I mean, that's the most we can do, right? I mean, some people are just unlucky. I have communicated with people who are elite level athletes, people that had great metabolic health on the surface that got cancer. So this challenges in many ways the metabolic theory. But when you talk to them, they're like, oh, well, I have, had Epstein-Barr virus, or I had, some kind of viral hit, or I was exposed to some kind of toxin. And it's kind of unfortunate because they believe maybe there's some things that they did that caused the cancer. And that's, I think, kind of unfortunate. But I do think that some people are just unlucky. And they could have a pre-existing gene, a SNP, or an environmental hit or toxin that, triggers an oncogenic shift and triggers a tumor cells to grow that form a tumor. So, and then the case with childhood cancers too, like they really haven't lived long enough to be metabolically dysregulated, to have poor metabolic health to get. So there's a lot of, I could see there's a lot of ways we can challenge the metabolic theory of cancer, but I think what's important from my perspective is that a rapidly growing tumor is highly glycolytic and is fueled by high glucose and high insulin and glutamine. And we have tools that we can target that. And also from the perspective that, I mean, it's appreciated now, right? I wrote the foreword to Travis Christofferson's book. And I really kind of delved into Tripping Over the Truth, and he would be a great guest to have on if you haven't. So in Tripping Over the Truth, that forward really just kind of delves into metabolic health, why it's important, and why a wide range of cancers are increasing due to poor metabolic health, and why we need to target that.
Well, let's take that part of the story now and run. So somebody has cancer. You've touched on the glutamine, glucose, the two fuels that we want to target. You've also talked about ketones. And I'm curious if you've come across any research showing that cancers can be fueled by these. Let's start off with that.
Yeah, I do think that some cancer cells can use acetoacetate and maybe beta hydroxybutyrate and ketones for biosynthetic production of lipids, and I think that's possible. I think more indolent cancers can maybe use fatty acids for fuel. So by indolent, I mean like kind of slower growing tumors like prostate cancer or things like that. However, the more aggressive and the more metastatic a tumor is, the more glycolytic it is, and the more a fundamental feature of that cancer, if you were to cut out the tumor and do an electron microscopy, the structure of the mitochondria would not look normal at all. The cristae would be almost absent or the mitochondria may look like hollow little shells without the inner mitochondrial membrane. So structure dictates function, and the more aggressive and glycolytic a tumor is, the less likely the mitochondria are serving in the capacity of ATP production. But that does not, they have other functions and could be biosynthetic processes and there's other functions associated with it, but it's less likely that they would be using fuels associated with oxidative phosphorylation, which are ketone bodies and fatty acids for fuels. And that's pretty much, I don't know too many people that would even challenge that. They may challenge the idea that that cancer, many still do believe, and I think in the lab and in various model systems, the mitochondria have normal oxygen consumption, and in some cases, in some cancer cell lines, maybe normal ATP production to some extent, but that's more likely an artifact of the model. But if you were, for example, to do biopsies of aggressive metastatic tumors, for example, glioblastoma, this has already been done, you'll find that there's a significant decrease in the number of mitochondria and a tremendous change in the structure of the mitochondria, especially the inner mitochondrial membrane. So that would challenge the idea that cancer is using fatty acids and ketones as a major fuel source. So they need to essentially default to fuels that are fermentable. And that includes glucose, of course, but also some amino acids, including glutamine, maybe alanine too, but glutamine for sure.
Well, let's get into the nuances of what targeting those looks like. We talked about the ketogenic diet. Makes sense. A diet like that is going to help bring blood glucose down and help bring insulin down. But let's get into the nuances. If somebody is in that critical state right now where they're battling cancer and they want to attack it by blocking best they can these two fuel sources that we know are part of the picture, what would you say?
Do everything possible to improve your cardiometabolic health. So you will be doing yourself a very big favor by incorporating a dietary intervention, a stress reduction intervention, and maybe even most important, and I haven't talked about it, in exercise, in aerobic exercise and strength training intervention. And when it comes to, when people who have advanced metastatic disease, they generally succumb to muscle wasting and cancer cachexia. And a big factor is the wasting of muscle, which limits their ability to their mobility. And then things go downhill very fast from there. So it's really important to build metabolic currency and also muscle as metabolic currency. So the first thing that I would do is, talk to your doctor, talk to your oncologist, ideally an open-minded oncologist who has an appreciation that the food that you eat and your nutritional status have profound implications on the outcome of this disease. So that's first and foremost. You need to have an oncologist who acknowledges that, appreciates that, and is going to support you. Because if you have an oncologist saying, don't do this approach, even if you're giving him papers, then that's going to create a lot of doubt in your mind. And what I've observed in just communicating with cancer patients over 10 years is that when certain patients, when they believe that the metabolic-based theory is working for them, that has a profound effect on the outcomes. And whereas, maybe other patients, and they may not be following through with all the different components of a comprehensive metabolic, based therapeutic approach, the outcomes are less favorable. So it's super important so I would say that up front. And then, as you eliminate all processed carbohydrates, stick to whole foods, reduce glycemic variability, do standard CBC, CMP blood work, get your insulin measured so you know that. And if you're overweight, if your BMI is, 28, 29, 30, if it's up there and it's not muscle, of course, and you have some fat to lose, it's important to follow an approach where you create an energy deficit, a caloric deficit. So that caloric deficit is further going to suppress insulin, glycemic variability, and also reduce many of the metabolic drivers for cancer. Whenever you have surplus calories, those surplus calories aren't going to end up feeding the tumor. However, if you create an energy deficit and a caloric restriction, then that's just going to marginalize the fuel to the cancer. What's really important when you create a caloric deficit is to do some kind of strength training and ensure that your protein is adequate, ideally 1.5 to 1.7 grams per kilogram, to preserve lean body mass and, if you can, build strength and muscle while you're doing it. And these are really important things that, an oncologist is never going to tell the patient to do. At least the way that I'm talking about it and giving specific, guidelines in regards to that. But I think another important aspect is to work with, the next thing to do is actually to seek out a trained diet consultant and to seek out information. It could be Miriam Kalamian's book, A Ketogenic Diet for Cancer. It could be different nutrition oncologists that I've worked with in the past. Beth Zupackini is very good. Denise Potter. You can look these people up, and they have been sort of the go-to people that have helped a number of patients. And there's an emerging amount of registered dietitians and consultants that work on this. And then to work closely with a consultant, or if you're educated enough to follow strict guidelines and to buy various monitoring off the shelf, commercially available in Walmart. I saw it the other day. Amazon, you get a Keto Mojo device. If you want to be fancy, you can get a continuous glucose monitor, but you want to be able to measure your glucose and your ketones and seek to get a glucose ketone index between 1 and 3. And that may be hard to do in the beginning. The standard American probably has a glucose ketone index of like 25 to 50. A low carb diet may push you down to like a glucose, low carb meaning 100 grams to 150 grams of carbs a day, maybe a glucose ketone index of 10. But when you get your carbohydrates down to 50 grams or lower, then you start to approach a glucose ketone index of 5. And then you can tweak things with a dietitian to maintain that therapeutic range. And there's very good data in animal model systems and emerging data in human outcome trials to suggest that a GKI of 1 to 3 is highly therapeutic. And not just for epilepsy, which is kind of my wheelhouse, but also for cancer.
And it's important to highlight the fact what we're talking about here is not bringing glucose down to zero. A lot of times, people in the
No, you can't
cancer
do
world,
that.
you can't do that. Even if you're water fasting, your body's going to make glucose and keep a stable level of glucose. It's going to be a lot lower than if you're having carbohydrates. But I just want to point out the fact is that we're looking at this GKI number and we're not just trying, because again, it comes back to the starve of glucose and glutamine. A lot of people in their head right away probably think about how do I get my blood glucose down to zero? And that's not possible or something you'd want to do.
No, there are very powerful homeostatic mechanisms that maintain your blood glucose within a very tight range. Even after I fast for 7 days, my glucose was like, 65, 70. So that is important. When you fast, you're liberating triglyceride from adipose tissue. The glycerol backbone can then be converted to glucose. Gluconeogenic amino acids can be converted to glucose. So lactate, if you're exercising through the Cori cycle, gets converted back to glucose. So your glucose may fall from 110, 120 down to half of that, to like 60 or 70 at the end of the fast. But I'm a little bit hesitant to tell people to fast if they have a normal body weight, especially if their BMI is kind of low. However, if someone has fat to lose and a high body weight, which is a large majority of people who have these metabolically associated cancers do have quite a bit of weight to lose. And one thing that I see in many people that communicate with me, especially those that are overweight when they're diagnosed, when they go into remission or have like what's called no evidence of disease after the therapy, most of them that communicate with me are just they're doing the standard of care, but they're coupling it with metabolic, and some of them are not. And like I was communicating with a glioblastoma patient that went over 10 years. When she was diagnosed, she was pregnant with her daughter, and she unfortunately just passed away a few months ago. But her daughter was 11 years old, and she was pregnant with her daughter when she was diagnosed with a glioblastoma. She did not do debulking. She did not do chemo. She did not do radiation. She did a calorie restricted ketogenic diet, fasting, and hyperbaric oxygen, and then some plant-based compounds too, like green tea and various other things, I believe. So, but we stayed in contact, and it was sad to see that she passed away. But it's important for people to look at the literature depending on what kind of cancer they have, and to ask their doctor, show me the randomized controlled trials on this particular drug and the outcomes, not only extension of life, but overall survival. It's going to be important. And to appreciate that outcomes can be highly influenced by the health and vitality and metabolic state of the patient. And I don't think that is actually, and I'm in contact with some of the top oncologists in the world, and they don't approach nutrition like that. So the nutrition is approached to mitigate side effects of chemo and radiation. So let's just keep calories, let's get calories in the patient, and let's prevent as much weight loss as possible. So that's kind of like the approach, right? And also to prevent any kind of nutritional deficiencies. So some things may impact, certain vitamin status. Some things may dysregulate the gut microbiome. So there's like probiotics and things like that. But they don't approach it from the perspective of further augmenting the therapeutic efficacy or targeting the tumor itself.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
These are really important things that an oncologist is never going to tell the patient to do. Hyperglycemia and hyperinsulinemia is associated with much greater, sometimes